So today we will discuss one of the most important chapters of the CNS, that is the antidepressant drugs. So depression, so already in some way or the other you have experienced the word depression during the preparations of the examination, during the preparations of your preparatory phase. So basically depression becomes a disease when it becomes pathological. So pathological depression means when there is continuous low mood, anhedonia, that is loss in pleasure in everything, hopelessness, feeling guilty, worthlessness, all this happens for a long period of time. So there are some definitions of the depression. That means if there is continuation of different types of the symptoms beyond 1 month or 2 weeks or like this, so there are different definitions. Accordingly, the depression is categorized. So with depression, the antidepressant drugs are basically helping the depression. Depression is also known as the endogenous depression. But apart from depression, there are different other diseases that is related to depression. For example, more common is the social phobia. So there may be some post-traumatic stress disorder. There may be some obsessive compulsive disorder. For example, kleptomania, you have heard the term. So there are different types of the neuralgic pain or unexplained pain symptoms, that is known as fibromyalgia, that is also a disease. So antidepressant is a group of drugs that is not only effective against the endogenous or major depression, but also effective many types of the affective disorder. The most common, I have given example, there are some phobic disorder, panic disorder, agoraphobia, kleptomania, obsessive compulsive disorder, different types of the neuralgic pains, different other atypical depression, like if there is depression with some psychotic components, depression with some anxiety components, etc., etc. So we will discuss this. That's why antidepressant drugs are very important. So basically, to give you a nutshell, what does all these antidepressants do? They are increasing the noradrenergic as well as the serotonergic transmission. These all are under the headings of the monoamines. So these are the monoamines, you know, adrenaline, noradrenaline, dopamine, serotonin, these are the monoamines. So basically in depression or in different types of the disease, there are some non-availability of these monoamines in the synaptic cleft. So basically when we are using the antidepressant drugs, we are increasing the availability or increasing the monoaminergic transmission into the synaptic cleft. So this is our motto. So by one way or the other, we are increasing the monoamines in the synaptic cleft. So this can be done either by blocking the metabolism of the monoamines in the synaptic cleft. So you know the monoamine oxidase is one of the mitochondrial enzyme that causing the metabolism of the monoamines, that is this noradrenaline, serotonin within the synaptic cleft. So we can block this. Again, there are some reuptake transporters like serotonin transporter ACRT or noradrenaline transporter NET in the presynaptic neurons that are reuptaking the excess monoamines and ultimately ending their actions in the synaptic cleft. So if we are blocking these reuptake transporters, ultimately what will happen? There will be more availability of these monoamines in the synaptic cleft. So these are some examples by which this is in very simpler terms why these antidepressants are helpful in increasing the monoamines in the synaptic cleft. So with this introduction, let's just start. Already we have discussed. So depression is basically a mood disorder. So this is also known as the affective disorder. So you can say this is a scale. On one side there is depression and the other side there is mania. So when there is euphoria, increased mood, that is also a disease that is known as the mania. So in the same scale, on the one hand there is depression and the other hand there is mania. So there may be some unipolar depression, that is only depression is there. In some patients there are bipolar depression or bipolar disease. So when there is alternation between the depression as well as the mania, that may happen. So changes in the mood are associated with depression either or mania. So disorders of the mood here happens rather than disturbance in thought or cognition. Disturbance in thought or cognition mainly happens when there is some types of the psychosis. So here we need mainly the antipsychotic drugs, but here this is the affective disorder where there is disorders of the mood happens. But often there is some overlaps, there may be some psychotic depression with some psychotic component that may happen. So clinical depression, feeling sad or different, there are some symptoms that is present more than 2 weeks. So symptoms of the depression, emotional symptoms are there, already I have discussed. So there may be some intense feeling of sadness, hopelessness, worthlessness, feeling guilty, anhedonia, feeling of guilty, indecisiveness, loss of motivation, lack of energy, interest, etc. There may be some biological symptoms like retardation of the thought and action. So what the patient is normally assumes to be done, they are not carrying out their normal daily activities due to the feeling low or feeling low energy. That may happen. Loss of libido, loss of appetite or sleep disturbance, both insomnia as well as sleeplessness, both can happen in some patients depending upon the patients. So depression is the most common cause of suicide. You all know depression, ultimately if the depression is not treated, many of the patients ultimately suicide can be the ultimate problem. And symptoms of the mania, anti-manic drugs, we will discuss this later. This is just opposite of depression, where there is a happy or excited or euphoric, self-confidence, lack of judgment is there, sudden odd decisions that are mostly of disastrous consequence. There are some flight of ideas, that is excessive rapid talking, moving quickly from one to another, hyperactivity, full of energy, sudden irritability, rage, impatience, aggression. So this is known as the mania. So this is one scale. On the one hand there is depression and the other hand there is mania. In many patients the depression and mania ultimately cyclically rotates. So again we have to use some anti-manic drugs with the antidepressant drugs in those patients. So there may be mild depression, moderate depression and severe depression. Severe depression means when there is some thought of the suicidal ideation is there. So unipolar depression, what I am talking, this is a major depression, unipolar, that is only depression is present, there is no other component of the mania. And bipolar depression is also known as the manic depressive illness, that is mania is present as well as the depression is present. There are some other forms what I am talking. So there may be some overlapping of the different other problems. There may be some psychotic depression, postpartum depression, this is quite common after the pregnancy, after the delivery, atypical depression, so depression with some atypical features. So now what are the possible mechanism of depression? Again, I have already given that depression is associated with insufficient central release of the norepinephrine and 5-hydroxytryptamine. So basically there is deficiency of the norepinephrine and 5-hydroxytryptamine in the synaptic cleft. Ultimately that may leads to depression. Development of the biogenic amine hypothesis. So this is the most common hypothesis known as the biogenic amine hypothesis or monoamine theory of depression. So it has been seen that monoamine theory, there are different types of the theory, all they are interlinked. The most common is the monoamine theory of depression. It clearly says by means of the different types of the examination that when there is deficiency or non-availability of the monoamines, most commonly the norepinephrine and 5-hydroxytryptamine in the synaptic cleft, that ultimately leads to depression. And mania results from its functional excess. So this theory is based on the ability to known antidepressant drugs to facilitate monoaminergic transmission. For example, reserpine, it can cause depression because reserpine depletes the monoamines, reserpine. Okay. So you can see this is the nerve endings, this is the when the action potential comes in the presynaptic terminal. So from the presynaptic terminal there are synaptic vesicles, within the synaptic vesicles different monoamines are stored. When the action potential comes, these monoamines are coming out from the synaptic vesicles, there will be availability of these monoamines in the synaptic cleft. Some part of these monoamines are taken back by means of the reuptake. There are different reuptake transporters are there. For example, norepinephrine transporter, serotonin transporter. Some part of is metabolized by the monoamine oxidase and some part goes in the postsynaptic receptor and ultimately the propagation of the action potential happens. So ultimately these areas monoamines are decreased in depression. So we have to increase the monoamines in this synaptic cleft. So when there is normal synapse, there is no depression. You can see there are so much monoamines. Some part of this MAO enzyme destroying the neurotransmitter, some uptake happens, some acts on the receptor. This is a normal cycle. But when there is deficiency, you can see the red ones. These are the monoamines. The monoamines, quantity of the monoamines are very much decreased, and some part of it is already getting metabolized and some part is getting reuptake. The same thing. And another hypothesis is the neurotrophic hypothesis. It says that brain derived neurotrophic factor and different other neurotrophic factors are also essential for the normal propagation of the mood. And there are some deficiency of these brain derived neurotrophic factors, and ultimately that leads to different types of the changes in the neuroplasticity and depression happens. But it has also been seen that when we are using the antidepressants for long period of time, they are also increasing this brain derived natriuretic factor. They are also helps in neurogenesis in these typical areas. So ultimately all these are interlinked. When we are using the antidepressants, they are helping both the monoamine hypothesis as well as the neurotrophic hypothesis. So now coming to the treatment of the depression, psychological treatment, pharmacological treatment, and lastly the electroconvulsive treatment. Psychological treatment means in some of the cases with the pharmacotherapy we have to give some psychological counseling, cognitive behavior therapy, and there are different types of the counselings are there. Pharmacological treatment is the most important. 70% of the depressed patients respond to antidepressants. And lastly, in some refractory cases, we have to use the electroconvulsive therapy, albeit it is lesser used nowadays because of the invent of the newer second generation antidepressant drugs. Now coming to the pharmacotherapy, antidepressants. So antidepressants usually do not act immediately. Remember this, usually they need minimum 2 to 3 weeks to manifest their effects. So if a patient is already getting some depression or something, we have to use the antidepressant drug minimum usually antidepressants are used usually 6 months to 1 year, and after that the patients are reviewed and the patients are well, then it is stopped. And the first manifestation of the advantages of the medicines are usually seen for 2 weeks or 1 month. The most consistent adaptive change seen with antidepressant drug is the down regulation of the beta, alpha 2 and 5-HT2 receptor. Alpha 1 usually not affected. So using these antidepressant drugs for long period of time, firstly there will be some more availability of the monoamines, and these monoamines can act on other receptors also. So that leads to down regulation of the beta, alpha 2 and 5-HT2 receptors, that is the other receptors. And the different antidepressants act on other receptors apart from their normal reuptake transporter receptors, and this leads to different types of the adverse effects also. So adverse effect varies from one agent to another, and this is due to the action of the antidepressants on different other receptors. So affect only people who are depressed. Usually in the normal people, if the antidepressant is given, that will not give any significant effect. Effect does not increase with increasing doses. Antidepressants are not habit forming. Antidepressants differ widely in side effects. What I am saying. So wide difference between one agent to another agent. So now classification of the antidepressants. Firstly, tricyclic antidepressants, and the newer congener of it is the tetracyclic antidepressant. Tricyclic antidepressant examples are the imipramine, clomipramine, doxepin, amitriptyline, amoxapine, maptropyline. These are the tetracyclics, desipramine, nortriptyline, etc. All of these are very common, very widely used in myriad of the cases. Monoamine oxidase inhibitors, MAO inhibitors, usually MAOA inhibitors are used. Example, tranylsapramine, phenelgin and moclobemide. Of this, moclobemide is the newer ones with lesser side effects. Selective serotonin reuptake inhibitors, SSRIs. Now these SSRIs or selective serotonin reuptake inhibitors are now the first line drugs for the depression, because they have lesser side effects than these tricyclic antidepressants, MAO inhibitors or some other agents. Examples are the fluoxetine, sertraline, citalopram, escitalopram, fluoxamine, paroxetine, etc. So this is the SSRI. Similar to SSRI, there are some other drugs, newer drugs that act on selectively on different receptors, and accordingly For example, serotonin and norepinephrine reuptake inhibitors are SNRI. SNRI example is the venlafaxine and duloxetine. So after SSRI, the most commonly used drug is the SNRI. Apart from this, there are some serotonin 2 antagonist and reuptake inhibitors or SARI. Example is nefazodone and trazodone, lesser used nowadays. Norepinephrine and dopamine reuptake inhibitors, NDRI, bupropion, mainly it is used in the smoking cessation. Noradrenergic and specific serotonergic antidepressant, example is mirtazapine. Mirtazapine is mainly used when there is severe insomnia associated with depression. Noradrenaline reuptake inhibitor, this is the newer ones, reboxetine, and serotonin reuptake enhancer like tianeptine. So basically these are different types of the atypical antidepressants, the same thing. These are the atypical antidepressants. So trazodone, mianserin, mirtazapine, bupropion, tianeptine, amineptine, atomoxetine, these are the atypical antidepressants. So you can say the older antidepressants are the tricyclic antidepressants and the MAO inhibitors, and the newer antidepressants are the SSRI, selective serotonin reuptake inhibitors, selective norepinephrine reuptake inhibitors or SNRI. SSRI and SNRI, these two are the important for usage in the patients as well as for the examination also. And there are some atypical antidepressants which act selectively on different receptors. I have given the previous one. All these can be grouped into one like atypical antidepressant. Okay. Now first coming to the tricyclic antidepressant. So tricyclic antidepressant is the one of the first used antidepressants, mildly used in different other indications are also used. Tricyclic. So there are 3 cycles, 3 benzene rings are there, you can see. Imipramine is the parent drug, and after imipramine, newer and different other tricyclic antidepressants are invented out. So here the oldest class of antidepressant, characteristic 3-ring nucleus, discovered is the imipramine. So the same thing, the names of the antidepressants are very commonly asked. You have to remember some names of each groups. Tricyclic antidepressant, this imipramine, clomipramine, nortriptyline, amitriptyline, doxepin, these 5 are very commonly used in patients. There are some newer tetracyclic antidepressants like maprotilin and amoxapine. So one benzene ring is added so that the adverse effects are lower. So the mechanism of action of the tricyclic antidepressants. So all tricyclic antidepressants block the reuptake pumps. So some part of these monoamines are metabolized by reuptake back, and these reuptake pumps are blocked both for the serotonin, that is the 5-hydroxytryptamine, as well as the norepinephrine in nerve terminals by competing for binding site of the transport protein. So ultimately there will be increased concentration of the norepinephrine and serotonin in the synaptic cleft as well as the receptor site. That leads to facilitation of the norepinephrine and serotonin transmission and improved symptoms of the depression. And there are different agents already you have seen. Some have more potency for inhibition of the serotonin uptake pump like clomipramine, imipramine and amitriptyline, and some have more potency for inhibition of the norepinephrine uptake pumps like nortriptyline and desipramine. So there are some difference. So you can see the same thing. This is the synaptic cleft and this is the reuptake pumps. Some part of these monoamines are reuptake back, and it is one of the most important part of metabolism of these monoamines, and this reuptake is blocked. But these tricyclic antidepressants not only blocking the reuptake of the serotonin reuptake pumps and noradrenaline reuptake pumps, they also act on different other receptors. Like they can also block some other serotonergic receptors, some alpha adrenergic receptors, histamine receptors, muscarinic receptors, and ultimately different agents acts on these receptors on different potencies. This leads to different grades of the side effects. So what are the pharmacological actions of these tricyclic antidepressants? When we are using this, they elevate mood, improve mental alertness and increase physical activity. Usually several weeks of the continued treatment is needed, already we have seen. In non-depressed patients, when it is used, in some cases they can lead to sedation, confusion and motor incoordination. And when we are using these agents, the norepinephrine and serotonin reuptake pumps are blocked instantly, but the antidepressant action usually takes some time to develop. Because this amine reuptake block by tricyclic initiates a series of time dependent changes, time dependent synaptic plasticity, and that culminate in antidepressant action. So when we are first using this, certain adaptive changes happens. Initially, the presynaptic alpha 2 and 5-HT1 receptors are activated. Since there will be more availability of the monoamines, that the other receptors on which the monoamines act, that becomes upregulated and activated, like presynaptic alpha 2 and 5-HT1. But with continued presence of the high level of these monoamines in the synaptic cleft, the other receptors are desensitized with period of the time. And ultimately the net effect is the enhanced norepinephrine and serotonin transmission. And with this continued high concentration, neurogenesis also happen. There will be more brain derived neurotrophic factor, and ultimately all this leads to synaptic plasticity and some adaptive changes in the neurons that helps in the culmination of the depression. Peak levels when we are using the tricyclic antidepressant 2 to 6 hours post ingestion. Usually these tricyclic antidepressants are bioavailability is good. They are orally available, orally good bioavailability is there. But this tricyclic antidepressants is highly protein bound. So there if some other drugs that can displace these tricyclic antidepressants from their protein binding sites, so there may be some increased concentration of the tricyclic antidepressants. And you all know that some depression patients are also taking some overdose of this tricyclic antidepressant. So there is also chance of the tricyclic antidepressant poisoning in some is there. They are lipophilic in nature, they are well absorbed from the GIT, cross the blood-brain barrier to penetrate the CNS, elimination by hepatic oxidation, and their therapeutic window is also very narrow. Usually the plasma concentration they act between 5 to 20 nanogram per ml. So if there is slightly higher or slightly lower dose, either there will be subtherapeutic effect or there will be toxicity. So tricyclic antidepressant is an example of the low therapeutic window or low therapeutic index drug. So they are metabolized in the liver mainly or by hydroxylation into metabolites. So these are the different agents. Strongly bound to plasma proteins already we have seen. Average TF is 24 hours up to 72 hours in overdose. That's why usually once daily dosing is sufficient. Large T-half and large volume of distribution. The volume of distribution reaches approximately 50 liter because tries are extensively bound to plasma protein and narrow therapeutic index. Already we have discussed. Side effects, already we have seen the side effects happens due to action of the tricyclic antidepressants on other receptors. For example, alpha receptors, muscarinic receptor, 5-HT receptor, different types of the other serotonergic receptor, cholinergic receptor, histaminergic receptor, etc. So what are the side effects? Anticholinergic, since they are blocking the cholinergic receptor. So anticholinergic receptor means atropinic side effects. So we are using the atropine, what will be the side effect like dry mouth, bad taste, constipation, epigastric distress, urinary retention mainly in the elderly patients when there is already enlarged prostate, blurring of the vision, a problem in the accommodation of the eye, palpitation, all this happens, anticholinergic side effect. There may be some sedation, mental confusion, weakness with amitriptyline and with more sedative congeners of the tricyclic antidepressants. Increased appetite and weight gain may happen. Some patients receiving any antidepressant may abruptly switch over to a dysphoric agitated state or mania. So when we are treating the depression, underlying depression, some patients may have some underlying component of the mania. So when the depression is treated by this, there will be flurried manifestation of the mania can also happen. So this is known as the dysphoric agitated state. So these are the cases of the bipolar depression, the other pole being unmasked by the antidepressant. Sweating, fine tremors can happen. Seizure threshold is lowered. So when there is increased propensity for the epilepsy. So those patients who are already epileptogenic, there will be more chances of the epilepsy. Postural hypotension, since the alpha receptors are blocked, especially in older patients, it is less severe with desipramine. Sexual distress is especially delay or interference with erection, ejaculation and orgasm. Cardiac arrhythmia, so this is the problem. When the tricyclic antidepressant is given, usually in the ECG there will be QT prolongation. So QT, so QRS complex, and after this there is T waves is there. So QT prolongation ultimately leads to the more chances of the cardiac arrhythmia. So that may happen in some patients, particularly elderly patients when there is already ischemic heart disease is present. Arrhythmia may be responsible for sudden death in some patients also. Amitriptyline and dosulfin are particularly dangerous in overdose. Higher incidence of the arrhythmia is reported with them. So that is these are the side effects of the tricyclic antidepressants. So this is important. So tricyclic antidepressants are lesser used nowadays because of these adverse effects, different types of the adverse effects. So acute poisoning of the tricyclic antidepressant, what I am telling, so it may happen in some when there is overdose is taken, excitement, delirium, other anticholinergic symptoms as seen in atropinic poisoning. So the symptoms are more or less like atropinic poisoning. Then the muscle spasm, convulsion, coma and death can also happen. Usually the treatment is done by the gastric lavage. So gastric lavage is done so that the tricyclic antidepressants will be lesser absorbed. So ultimately it is coming out. Respiratory assistance, fluid infusion, maintenance of the blood pressure, temperature. Acidosis is corrected by bicarbonate. Diazepam is used for the convulsion and delirium, and most important is the treatment of the cardiac arrhythmia, for which propranolol or lidocaine may be used. So propranolol you have already read in the beta blocker chapter. So propranolol is a drug for cardiac arrhythmia. Lidocaine or lignocaine, this lidocaine already you will read in the antiarrhythmic drugs that lidocaine is a local anesthetic drug, you have already read, but this local anesthetic drug also have antiarrhythmic property, so this can also be used. So acute poisoning of the tricyclic antidepressant, remember this, the symptoms are more of like atropine poisoning. Interactions, since this is also another adverse effect you can say, since the tricyclic antidepressants are highly protein bound, they are metabolized by different cytochrome enzymes, they are acting on different other receptors, so different foods, different drugs can interact with this, and ultimately that leads to different types of the problems. So they are metabolized by the liver microsomal enzymes, so they very common interactions with oral contraceptives, other antipsychotic drugs, SSRIs, barbiturates, etc. This tricyclic antidepressants should not be given to MAO inhibitors. So hypertensive crisis can also happen. So increased blood pressure can happen when these tricyclic antidepressants are given with MAO inhibitors. So you can see tricyclic antidepressant, when it is used with MAO inhibitor or directly acting adrenergic drug, there will be more availability of this tricyclic antidepressant drug. So there may be some hypertension, hyperpyrexia, that is the body temperature is very much increased, convulsions, coma can happen. With directly acting adrenergic drug, there will be more availability of these monoamines, again this hypertension, hyperpyrexia can happen. Again when there is usage of the ethanol or other CNS and depressants or indirectly acting adrenergic drug, their actions will be decreased. So there will be toxic sedation, they block effects of this. So if the patients are of suicidal tendency, so there will be more chances of the suicide. Since the therapeutic index is very narrow, the subtherapeutic effect is also, the depression will not get treated, so that is also a problem. So that is the problems of the tricyclic antidepressant. Amoxapine is basically, it is a tetracyclic antidepressant, newer ones. It blocks dopamine receptors in addition to inhibiting the norepinephrine reuptake. So it is chemically related to the antipsychotic drug, and it is commonly used when there is some antidepressant, some depression with some psychotic component is there. So we have to use the antidepressant plus antipsychotic drug. These antipsychotic drugs are also known as the neuroleptic. We will read this later. So risk of extrapyramidal side effect is also there, because in antipsychotic drugs, first generation antipsychotic drugs, the most common side effects is the extrapyramidal symptoms. We will read this in the antipsychotic chapter. So contraindications, tricyclic antidepressants should not be used in patients in glaucoma or with enlarged prostate because of their atropine-like actions. So anticholinergic action, atropine-like action. So in those cases where the atropine should not be given, again the tricyclic antidepressants should not be given. So glaucoma, so the angle of the narrow angle, it becomes more narrow. So there may be some absolute glaucoma precipitation, or in enlarged prostate, if using this, there may be some urinary retention. So anuria can also happen. So no urine. So we have to catheterize that patient. Tricyclic antidepressants are contraindicated in manic depressive illness. Already we have seen. So when there is bipolar illness or manic depressive illness already diagnosed, we should not give tricyclic antidepressant because that leads to some dysphoric agitated state. Next, coming to the monoamine oxidase inhibitor. So tricyclic antidepressant, after this tricyclic antidepressant, the next group is the monoamine oxidase inhibitor. So these are the examples of the monoamine oxidase inhibitor: phenelgine, tranylcypromine, isocarboxazide, moclobemide and pargailin. Again, the onset of the antidepressant actions is approximately 2 to 4 weeks. Now this monoamine oxidase is found nearly all tissues and is located intracellularly associated with mitochondria. So these are mitochondrial enzymes mostly present at the synaptic membrane, neuronal membrane as well as the platelet membranes. So this monoamine oxidase ultimately monoamine oxidase, so they are metabolizing the monoamines present in nerve terminals that release norepinephrine, dopamine and 5-hydroxytryptamine located on the surface of the mitochondrial membranes. It deaminates and inactivates any excess norepinephrine, and it is not involved in the inactivation of the release transmitter. Okay. So you can see this is the normal monoamine transmitter. So this monoamine transmitter inactivates the monoamines that leak from a synaptic vesicles. Okay. So effect of the it inhibitors. So when we are inhibiting these monoamines, they prevent the inactivation of the monoamines within a neuron, causing excess neurotransmitter to diffuse into the synaptic space. So when we are using this, its metabolism is decreased and there are some excess neurotransmitter is also released, because some part which is diffusing from the synaptic vesicles and the presynaptic nerve terminals, they are coming to the synaptic cleft, so there will be more availability of these monoamines. So monoamine oxidase inhibitors increase the availability of the monoamines in the synaptic cleft. So there are two types of the monoamines, monoamine oxidase A and B. Two types is there. A is mainly metabolizing the norepinephrine, serotonin and tyramine. Inhibition of the monoamine oxidase A usually produces the antidepressant effect, remember, and MAOB is specific for the dopamine, and inhibition of this MAOB produces anti-Parkinsonian effect. So when you read about the management of the Parkinsonism, anti-Parkinsonian drug, you read about the MAOB inhibitor, selective MAOB inhibitor. And in the antidepressant, mainly we are using the selective MAO-A inhibitor, because there are some non-selective MAO inhibitors also, but there will be more adverse effects of these. So this is the irreversible and non-selective MAO inhibitor example. Irreversible means ultimately it destroys this monoamine oxidase enzymes and until the new enzymes are secreted. So these are the classic monoamine oxidase inhibitor example: phenelgine, tranylcypromine, isocarboxazide and pargailin. It cannot distinguish between these two isoenzymes A and B. They cannot be restored until the new enzyme is synthesized. Therefore, the effect of this MAO inhibitor persists for a period of 2 to 3 weeks after stopping the treatment, where a new or fresh enzyme has to be synthesized. So in spite of the stoppage of the treatment, its effect usually persists for the 2 to 3 weeks. Next is the reversible and selective inhibitor of the MAO-A. Normally this is used in the treatment of the depression. Example is this is a newer drug, moclobemide. This is a reversible and selective inhibitor of the MAO-A, short acting antidepressant action, and there are some selective inhibitor of the MAO-B mainly used in the neurodegenerative disease or Parkinsonism like deprenyl or selegiline. You read this in the Parkinsonism and other neurodegenerative disease chapter. So what are the side effects of these MAO inhibitors? First is the hypotension. So when these MAO enzymes are inhibited, other amines, for example dopamine is usually not inhibited by this, are able to accumulate in peripheral synaptic nerve terminals, and this dopamine can displace the other monoamines like vesicular norepinephrine, thus reducing norepinephrine release, and sympathetic activity are reduced. So this is known as the sympathetic block. So when the sympathetic block happens, the patient ultimately feels the dizziness, postural hypotension in different periods of the time. So that may happen due to the usually this happens due to the non-selective MAO inhibitor. Anti-muscarinic effect, similar thing, atropine-like side effects like that of the tricyclic antidepressant like dry mouth, blood vision, urinary retention. CNS stimulation can happen like insomnia, tremors, excitement, convulsion, weight gain can happen. So there are more drug interactions with MAO inhibitors also. For example, pethidine. So pethidine, morphine, like morphine, there is another thing is the pethidine. It interacts with this opioid receptor agonist. So there may be some hyperpyrexia, restlessness, coma, hypertension can happen. Levodopa, you read this levodopa in the Parkinson chapter, one of the important drugs. Again, when these are used with levodopa, there will be hypertensive crisis. So there will be severe rise of the blood pressure. Amphetamine and ephedrine, these are the indirectly acting sympathogenic amines. You have read this in the ANS chapter. So they can interact with the MAO inhibitor. They cause liberation of the accumulated monoamines, and again the hypertensive crisis can happen. With tricyclic antidepressants, already we have seen both of these can lead to hypertensive crisis, and with the SSRIs also they lead to serotonin syndrome. Serotonin syndrome or cheese reaction, we will come to this. So cheese reaction is also very important. What happens? There are some foods like cheese, wines, beer and some other fermented food where there is more availability of the tyramines, tyramine or tyramine containing food. So these are the indirectly acting sympathomimetic amines. So tyramine rich foods, when these are taken with MAO inhibitor, for example, old cheese, concentrated yeast products, pickled fish, red beans, red wine, chicken liver, sausage, etc. Now this tyramine is normally degraded in the gut by the MAOA. So that is the problem. So they are very much rich in the tyramine. So tyramine is the indirectly acting sympathomimetic amines. Sympathomimetics ki kore? So ultimately they cause sympathetic activity, increase the heart rate, increase the blood pressure. So they are basically metabolized by the monoamine oxidase A. So when we are using the monoamine oxidase inhibitor, non-selective or selective MAOA inhibitor, so this tyramine will not be metabolized due to the absence of this, due to the blockade of the monoamine oxidase. So there will be more availability of this tyramine, more availability of this indirectly acting sympathomimetic amines. So you can see tyramine from ingested food is normally absorbed and taken up, and it is converted to octapamine, which is a false transmitter which causes massive release of the norepinephrine and may result in hypertensive crisis. Severe hypertension, severe headache, fatal intracranial hemorrhage, that means stroke, that can happen. So this is known as the cheese reaction. This is very important for your examination also. So cheese reaction mainly happens when the monoamine oxidase inhibitor and also with some SSRI also, they are taking with some tyramine rich foods. Tyramine rich foods are some old fermented yeast products. There may be some red wine, different types of the beers, different types of the old cheese, chicken liver, different smoked fish, sausage. When these are used, the tyramines will not get metabolized by means of the MAO inhibitor. These tyramine are changed to a false neurotransmitter known as the octapamine. This octapamine ultimately displaces the norepinephrine from their storage sites. So there will be more massive release of the norepinephrine into the circulation. This norepinephrine acts on the heart, this norepinephrine acts on the peripheral circulation, and this leads to massive increase of the blood pressure, hypertension, and due to this massive release of the blood pressure, there may be some intracranial and intracerebral hemorrhage can also happen, headache, etc. can happen. So what will be the treatment of this cheese reaction? So we have to use some alpha blocker like prazosin or phentolamine. So you have read in the alpha blocker chapter in the ANS, prazosin is the selective alpha blocker, phentolamine non-selective. So prazosin or phentolamine is given. At least 10 milligram of tyramine needs to be ingested to produce this reaction. So it means slight amount of the tyramine will not cause. Ultimately, it will get replaced by the norepinephrine. But more amount of the tyramine containing foods leads to this. The special advantage claim for moclobemide is that no cheese reaction occurs with its use. So moclobemide is the reversible. That's why reversible. The other agents are the irreversible. It usually takes 2 to 3 weeks time for its action to wane away. But moclobemide, since it is reversible, so it can ultimately replace. So moclobemide usually no cheese reaction happens. So it is a reversible or selective MAO inhibitor. Short duration of action, full MAO activity is restored within 1 to 2 days of the stopping the drug. Competitive enzyme inhibition, tyramine is able to displace it from the enzyme. So you can see that's why even if stoppage of the MAO inhibitor, mainly the non-selective MAO inhibitor or other MAO inhibitor apart from the moclobemide, there is no drug but even after 2 weeks or 3 weeks, the patient eats some red wine or something, there may be chances of the cheese reaction, because its action persists for 2 to 3 weeks after that, because these are the irreversible inhibitors. But moclobemide is a reversible inhibitor. Its effect wane off within 1 to 2 days. So this is the difference. And this moclobemide also lacks the anticholinergic, sedative, cognitive, psychomotor and cardiovascular adverse effects. That's why it is safer in the elderly. Particularly good option of depression in the elderly patients and in those with heart disease and social phobia. There are some limited adverse effects not needed. So remember, cheese reaction, MAO inhibitor cheese reaction is not seen in moclobemide. Why it is not seen? Because this of reversibility of action, short duration of action. Moclobemide is particularly used in the social phobia as well as the depression, mainly in the elderly persons. Okay. Therapeutic use considered to be now the last line agent to drug food interactions. So after the SSRI or SNRI and then tricyclic antidepressant, if the patient will not respond, then the monoamine oxidase inhibitors are used. Or in some atypical depression or phobic states, this can be used. Next, coming to the SSRI or selective serotonin reuptake inhibitor. Now these are the first line agents for the treatment of the depression. These are the agents already we have seen. Very important, all of these are very commonly used: fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram, escitalopram. You have to remember the names. The SSRIs are currently the most widely used. They act within the brain to increase the amount of the neurotransmitter serotonin in the synaptic gap by inhibiting its reuptake. They are selective because the main difference between with the tricyclic antidepressant is that they are acting less with the other receptor. That's why the side effects are the less. That's why it is most commonly used. So SSRIs lack some of the side effects of the more general drugs. So you can see SSRIs have delayed onset of action extending to several weeks. Again, they blocks the serotonin reuptake pumps. So you can see this is the reuptake pumps, they are blocked. Ultimately, there will be more availability of this serotonin as well as the some part of the norepinephrine, and this ultimately leads to some changes in the receptor desensitization or down regulation, and there will be some synaptic plasticity release, there will be neurogenesis, more serotonin will be available in the synaptic cleft, neuronal impulse flow is also increased. So all this leads to changes in the some synapse changes. This change is known as some neuroplasticity. So neuroplasticity happens when a long duration of the SSRIs are usually given, and already we have seen several weeks is usually needed for its action. Now the advantage of the SSRI. So what are the disadvantages of the tricyclic antidepressants? So these are not present here. That's why this is the advantage. So this is also very important questions for you. Why the SSRIs are usually preferred over tricyclic antidepressants? Very common. So they produce little or no sedation, do not interfere with cognitive or psychomotor function, or produce anticholinergic side effects. So already we have seen anticholinergic side effects are the main side effects of the tricyclic antidepressants, and also MAO inhibitors. This is lesser present here. They are devoid of alpha adrenergic blocking actions, so there will be less chances of the postural hypotension does not occur, making them suitable for elderly patients. Again, this alpha receptor blocking action is more with the tricyclic antidepressants, also present with the MAO inhibitors. They have practically no seizure precipitating propensity. So epileptogenic activity is also less. This is more with the tricyclic antidepressant. Arrhythmia, arrhythmogenic potentials, that is causing the cardiac arrhythmia, this is also less with this. Weight gain is not a problem. In contrast to MAO inhibitor, they do not cause chase reaction. They can cause serotonin syndrome, but this is milder in comparison to the chase reaction. Acute toxicity is less than that of the MAO inhibitor or tricyclic antidepressant. So if there is overdose of the selective serotonin reuptake inhibitor, usually the changes or usually the manifestations are the less acute. The patient can be salvageable. These are the fluoxetine is the first SSRI that was used. It is a bicyclic compound. Half-life of the fluoxetine after single dose is 2 days and after multiple dosing is 4 days. Basically, it is metabolized in the liver. In the liver, P450-2D6 enzymes is usually used, and it is also approved for use in children greater than 7 years and adolescents, and relatively safe in pregnancy. So you have to remember only this. Fluvoxamine is a shorter acting SSRI with a T-half of the 18 hours with no active metabolite. It is specifically used for the generalized anxiety disorder and obsessive compulsive disorder. So fluvoxamine is now the one of the fastest drug for the obsessive compulsive disorder. Obsessive compulsive disorder means when there is some compulsion to action due to some obsession and ultimately it repeats. For example, someone just checking their locks with the key, whether the lock is given well or not, repeatedly. So this is known as the OCD, obsessive compulsive disorder, or someone is washing their hands repeatedly like this. Relatively more nausea, dyspepsia, flatulence, nervousness can happen. Discontinuation reactions are also there. Paroxetine is another short acting SSRI. It does not produce active metabolite, but there are some higher incidence of the gastrointestinal side effects. Sexual distress, agitation and discontinuation reactions can happen. Sertraline is very commonly used nowadays. The adverse effects are quite less with this. It is chemically unrelated to other SSRI. Efficacy is very good in the juvenile depression in the children. It is recommended for anxiety and post-traumatic stress disorder. So post-traumatic stress disorder, if there is some trauma, some traumatic incidents with their life, there may be some post-traumatic stress disorder. In these cases, sertraline is very good drug for the treatment. Drug interactions are less. Plasma T-half is very high, 26 hours. It appears to also a minor inhibitor of the dopamine reuptake. Citalopram and its congener escitalopram, these are also very commonly used. Lower propensity to cause drug interactions. T-half is very high, 33 hours. Few deaths may happen in some of the cases. Citalopram is the preferred SSRI for mood disorder in premenstrual symptom. So premenstrual dysphoric syndrome. Before menstruation, there may be some depressive episodes. Here it can be active. Escitalopram, its enantiomer, which is the adverse effects are quite less in comparison to the citalopram and more commonly used nowadays. Dapaxetin is another SSRI, is mainly used in the premature ejaculation. It acts rapidly, can be taken 1 hour before sexual intercourse. Side effect is the nausea, vomiting, loose motion and headache. So dapaxetin mainly used in the premature ejaculation, not used in other depressive cases. Adverse effect of the SSRI, the more common is the gastrointestinal symptoms. So in tricyclic antidepressant, there are myriad types of adverse effects. These are not present in the SSRI, but gastrointestinal adverse effects are there. There may be some nausea, vomiting, diarrhea. There may be some bleeding to the stool can also happen. Changes in appetite, weight loss or gain can happen. Sleep disturbance, drowsiness with fluvoxamine happen. Anxiety and tremor can happen. And with some agents, there may be some sexual dysfunction like loss of libido, delayed ejaculation can happen. So you can see all these can be used for the treatment of the sexual disorder, but some agents can also lead to some adverse effect of the sexual disorder that can happen. And there are some discontinuation syndrome. So when we are discontinuing the drug, ultimately that leads to headache, malaise and flu-like symptoms, agitation, irritability and nervousness. So that can happen. So usually the doses are gradually decreased and ultimately it is stopped. Drug interactions are there with SSRI, but it is less in comparison to the MAO inhibitors as well as the tricyclic antidepressant. Serotonin syndrome is a smaller or minor version of the cheese reaction. So there may be some tremor, hyperthermia, cardiovascular collapse. In selective cases, that can also happen when there is this SSRI is given with MAO inhibitor. So there will be some increased chances of this. So this is known as the serotonin syndrome. So this is different from the cheese reaction. There are some norepinephrine selective reuptake inhibitors or NRIs. This is known as the reboxetine and tamoxetine. So they are selective, they are inhibiting selectively the norepinephrine uptake, maybe more effectively noradrenaline deficiency syndrome. For example, when there is depression associated with fatigue, apathy, cognitive disturbance, etc. Mainly it lacks the antagonistic activity at H1 muscarinic adrenergic receptors. There may be some fewer unwanted cardiovascular effects. So just remember the names and the groups, and mainly used in the when there is depression associated with fatigue. SNRI, this is important. SNRI is more commonly now is used in different types of the neuropathic pains. Okay, that mainly this venlafaxine, desvenlafaxine, levomirancipran and duloxetine. Of this venlafaxine and duloxetine, these two are commonly available in our country. Desvenlafaxine is also available, are commonly used. They inhibit the reuptake of both serotonin and norepinephrine, but selectively. their actions on other receptors is very less. Effective in treating depression, in whom the SSRI is also ineffective. So they are more effective when in case of the refractory cases. Sometimes effective in relieving pain associated with diabetic peripheral neuropathy, post-therapeutic neuralgia, fibromyalgia, low back pain. Now this duloxetine is the first line drug or the drug of choice in case of the diabetic peripheral neuropathy. So in case of the long standing diabetes mellitus, there may be peripheral neuropathy, the patient may complain of tingling or burning sensation in the legs or severe pain in the legs. So this is known as the diabetic neuropathy. Now duloxetine is the first line drug for the treatment of the diabetic neuropathy. If it is not controlled, then duloxetine can be combined with some other drugs like gabapentin or pregabalin. You will read gabapentin, pregabalin in the anti-epileptic chapter. Okay. So these are used apart from the depression in different types of the neuralgic pain. Post-therapeutic neuralgia. So herpes zoster, you have probably heard its name. So after the chickenpox in the young ages, in some persons after ages, in the older age, there may be some remanifestation or recrudescence of this herpes. This is known as the herpes zoster. It comes with the rashes and there will be severe pain. Unilateral rash usually happens either in the mouth or in the chest. Severe neuralgic pain happens. The patient cannot wear the clothes because the friction with the clothes ultimately leads to severe pain. So that can also be decreased by means of this SNRI. Okay. So these are now the mainly drugs for the post-therapeutic neuralgia, peripheral neuropathy. Fibromyalgia means unexplained pain. There may be some unexplained pain, some somatic pain. Some patients may complain that আমার সারা শরীরেই ব্যথা করছে, সারাক্ষণ বল দেখবি তোরা. So there may be some unexplained pain, that may be some depressive component also. In those cases, SNRI is also very much effective. So they have little activity on other receptors, already we have seen, and there may be some discontinuation syndrome also. So SNRI, serotonin-norepinephrine reuptake inhibitor, venlafaxine, duloxetine, desvenlafaxine, these are important. So these are the sites of the different antidepressants already you have seen. So tricyclic antidepressant and SNRI, they can block this norepinephrine transporter. Tricyclic antidepressants also block the other receptors like alpha-1 adrenergic blocker, beta receptors, alpha-2 presynaptic receptors, etc. These 5-HT other receptors, etc. This SSRI, SNRI, tricyclic antidepressant, all these three blocks the serotonin transporter. So you can see the monoamine oxidase blocks this monoamine enzymes. So ultimately there will be more availability of these monoamines. So in the nutshell, these are the mechanism of actions of the different types of the antidepressant drugs. So you can see their actions of the norepinephrine and serotonin differs between one agent to another agents. So there may be some types of the depression or some types of the other diseases where the norepinephrine component needs to be checked more, and in some components the serotonin needs to be checked more. So accordingly different agents are usually chosen. For example, fluoxetine, you can see there will be no norepinephrine reuptake inhibition but very high serotonin reuptake inhibition. On the other hand, venlafaxine and duloxetine, already we have seen these are the SNRI, so they are blocking both these. So norepinephrine and serotonin block. Tricyclic antidepressants, more norepinephrine blockade and lesser serotonin blockade, like this. So this is giving just the understanding. So there is some agent to agent difference between their actions on the different reuptake proteins, between their actions on different other receptors. Atypical antidepressants, just remember the names and their usage. For example, bupropion. Bupropion is a norepinephrine and dopamine reuptake inhibitor. Bupropion has excitant rather than sedative property. Mainly it is used in case of the smoking cessation. Okay. So you can see useful for decreasing cravings and attenuating withdrawal symptoms in nicotine in patients trying to quit smoking. You will read about more agents for the smoking cessation, but bupropion is one of the important agents for the smoking. So after the cessation of the smoking, there may be some cravings. That's why the patient again continues their smoking. So these cravings can be decreased by using the bupropion. Side effects are the dry mouth, sweating, nervousness, tremor, etc. can happen. Contraindication if the patients are at risk of seizures, some eating disorder, bipolar disorder, etc. Another is the trazodone and nefazodone. They are serotonin 2A receptor antagonists as well as the reuptake inhibitors. So they are reuptake inhibitors as well as the serotonin receptor antagonists. Basically, they reduce the risk of anxiety, sedation, or sexual dysfunction, which is normally associated with the SSRI. Mostly it is used in some refractory cases when the normal antidepressants will not act.